Okay, so I hope that you can see me and also you can hear me. We had some technical issues to launch our planned live, but thanks God, thanks internet, that we are able to do it now. Just need few minutes to arrange some technical stuff before I will start answering your Q&A, your questions. Actually, I would like to ask you if you can hear me. Please write in the chat. I will also open my YouTube on laptop, so I'll be able to see myself as well. So please, if you can hear me, just write down in this chat that, or just put some plus or whatever. Just I want to see if everything is fine from our side. Okay, and actually, that will be also great to see which country are you from, because we have no limits due to internet. We can do live broadcast from every single country in the world. So I would like to know which country are you from, guys. Please write down in the comments where are you from, and yeah, so perfect. Now finally I can see all these charts and everything. So I can see that you are from Ukraine, from Peru, from Iraq. We have people from Egypt, from again from Ukraine, from Latvia. That's nice. That's actually great because we have possibilities to, to communicate with no limits, with no borders. Thanks, guys, for joining us. It's a big pleasure for me to be able to communicate with the audience. Being in Czech Republic in Prague, I know that you are very busy nowadays because of the Christmas holidays. Some preparations, arrangements. Probably you are getting information where to spend your winter holidays, searching for the hotels and the resorts. Yeah, so thanks for joining us. We will just start our answering your questions in a few minutes. Just let's go. We can see people from Ukraine again, from Iraq. That's great. That's nice. Perfect. This live broadcast will be in English, so I will just get a few announcements in Ukrainian language, in Russian language. So, дорогі колеги, дорогі колеги, даний ефір буде проводитися англійською мовою. Тож слухайте англійську, можете перекладати. Я буду намагатися робити це як то кажуть, англійська в голові. Буду намагатися це робити простими словами. Тобто, дуже сподіваюся, що цей ефір ви зможете зрозуміти. Постараюсь на английском языке простыми словами провести этот эфир, и вы сможете его понять и простить. Okay, guys, so let's go. Again, Egypt, Arabic. That's very nice. That's great. Perfect. So, my friends, first of all, I promise you that we will be spending a little bit more time in our YouTube channel. We didn't have possibilities to go live or to upload videos recently, but I hope that next year we'll have a little bit more time to upload our new content, to continue our video sessions, to continue our educational series, webinars, and so on and so on. Okay, so the first question. We actually announced this live broadcast a few days ago, and in our Instagram, we asked questions. What would you like to discuss? And we got some interesting questions that I'm really happy to start answering. And I would start with one very important, as I think, as far as I think. So the one question from our colleague Which dentist has influenced you the most in your professional career? So that's the question. Which dentist influenced you most in your professional career? That's actually a good question, actually. A good, and from one side, it's very easy to answer. From another side, it's pretty difficult to answer because there are many dentists, many colleagues, many professionals that influenced and continuing influencing myself as professional. So it's very difficult to really name the only one. But I can tell you that before going into university, when I was just fresh graduated from the secondary school, and I was about to think which direction to follow, which university to go, which specialty to go for. There was a man. He is actually a very good friend of my father. Actually, he is a friend of our family, and he's a dentist. And my father has medical education. He is a general doctor. And actually, I was thinking when I was in a school, I was thinking to also to become a doctor. Okay, so medical university was chosen as the way to follow from the very young age, let's say. But when it came to make a decision exactly where to go, and this guy, the man, his name is Igor, he came to us and said, Maxim, since you want to join medical university, why don't you want to go to dentistry for dentistry? And actually, that was a point. And I said, "Oh, okay, I have no idea what is medicine, what kind of directions, I mean, in details. So I decided, let's go, let's follow his advice. And actually, he's the one who influenced me to become a dentist, the dentist of the friend of our family. So because of Igor, his name is Igor, and the surname is Vanchenko. He's very advanced and very experienced now. He's my father's age. He's still practicing, and actually because of him I became a dentist. Actually, I enrolled dental university. Okay, and then I got a lot of motivation from other professionals like Sergei Rodlinsky from Ukraine, restorative direction, Didier Dici, Pascal Manier, Christian Kochman, John Coyce, and many others. Okay, let me answer the question from this chat. There is a question. Hey Doc, I love the BG dental cases. I learned a lot from them. Are you gonna upload videos again? Yes, yes. As I told you, we next year we will try to upload these BG dental cases in more regular basis. So be in touch. You will see some interesting content is coming very soon. Okay, next. Hello, a patient with a total rehabilitation, mandibular advancement, and let me just yeah, total rehabilitation, mandibular advancement, and increasing vertical dimension was done. Patient on provisional restorations. How do you transfer mandibular position from provisionals on definitives? Okay, so I would rephrase a bit this question, and I will give you some tips and tricks. So when you have big full mass rehabilitation case, when you have mandible reposition or mandible misplacement, you define the new vertical dimension when you provided like functional diagnosis, and then you decided to go for that situation with a new mandible position and with a new vertical dimension, and now you have provisional restorations. This is what I understand from your side. And now the question is how to transfer these provisional restorations into the finals. There are two ways, actually, not two ways, sorry. There are many ways to do that. I would like to share with you a digital way, which I think is way more easier when you do digital, when you have intraoral scanner, and then you can really transfer the new position to your dental lab in easy way. First of all, you scan your provisionals. If you're really sure that everything is fine, you scan your provisionals. So you have these files that will be used by your dental technician. But one important thing before I continue answering that, your dental technician has also to have your new mandible position and a new joint jaws mounted in articulator in a digital articulator, for example, in Hexagon. So basically, you have your mandible, you have your maxilla in a digital articulator, in a new position, in a new vertical dimension, in which you made your provisional restorations. That's it. Then you scan your provisionals in a patient's mouth. So you will send these files to your dental lab, and then they can correlate these files with you with a project to see if everything works fine or not. And then I would, for example, if you want to scan also prepped teeth, or for example, you have your provisionals, and then you decide that you need to make some preps adjustments, and then you will send this to your dental technician. So first you scan your provisionals, then you will remove uh, provisionals, but not all of them. You can remove some are provisionals, like for example, we remove all except last molars and canines. So basically, we have like 7, 7, and 3 and 3 provisionals. The rest are prepped, or the rest I'm going to prep, for example, or to modify my prep. So I adjust preparations on the first molars, second premolar, first premolar, and incisors, and then I scan. And this file will be easy for your dental technician to correlate with your digital articulator, because on your intermediate file, we call it intermediate file, you have still last molars as provisionals and canines. So these last molars and canines will be really easy to correlate with your initial project that is in a digital articulator, or with your biocopy scan, which was your scan of your provisionals. Okay, and then you remove, in patient's mouth, you remove last molars and these canines, you reprep them, and then you scan all the arch with a prepped teeth. And this scan with a prepped teeth will be correlated in easy way with intermediate scan that is already in the new position, and then your dental technician will do final restorations based on the new vertical dimension. Okay, so this is the way when you do in a digital way, but we usually do it in a little bit more simplified. So first of all, in the full mass rehabilitation cases, when we provided the functional diagnosis, and we determined the vertical dimension, the position, and everything, then we can check everything. We can check everything with a splint, for example, and then if we finalize the position, we have our jaws mounted in our digital articulator, in which our project will be performed. So dental technician will do a digital wax up in that new position in a digital articulator. Then I have my patient, and I will start preparations. Like, my patient has initial situation, I don't have any provisionals, so I start preparations, and I do preps the same way as I explained. I prep everything except 7 and 3. Okay, to 7 and to 3. Scan, prep teeth. So this will be correlated with our initial model in a digital articulator in a new position. Then I prepped canines and second molars. Scan again. Then we have all full arch prepped. This scan will be correlated with the intermediate scan, and everything will be in a new position. And our dental technician will do provisional restorations on our prepped teeth, and then I mount these provisional restorations in the patient's mouth. We correct them if needed. We check everything, and then I just scan these provisionals in patient's mouth, and our dental technician may correlate our preps already that I performed later on with provisional restorations after some kind of adjustments if you made these adjustments in patient's mouth. In a conventional way, if you do conventional, you're not doing digital, you do conventional way. In that case, you may do cross-mounted procedures. So you have your modules mounted in a physical articulator, initial modules, and you have your wax up done in that position, but your dental technician may have duplicate of maxilla and mandibula also in that position in which the wax up will be done. Then you will have your bite plate, so-called bite plates for preparation. So you prep in patient's mouth some teeth you do not prep. Then you reline this bite plate with a bite registration material, and then you prep the rest, and then you have your impression, and then you have your bite plate, and you have your bite plate on the jaw that you prepped, and this bite plate may be mounted in articulator to the antagonist jaw that is waxed up already, and then your dental technician will do your provisional restorations and so on and so on. It sounds a little bit complicated, but I think that maybe in the future, maybe next year, we will do some kind of videos about that, and I will show you by slides how do we transfer the mandible position or new vertical dimension position to our dental technician in a full mouth rehabilitation cases in a digital workflow and in a conventional workflow. Okay, so let me go through your questions. Thank you for answering my question. Looking forward to seeing your new videos. When are you coming in to lecture in Spain? I'm not planning to travel a lot next year, honestly speaking. I plan to do as many courses as we can in our training center. This is training center that you can see in Prague. It's a brand new. We just launched this location in November, and we have provided few courses already. So people from many countries already join us. So actually, it's good for you to come to us, not for me to come to your country. Okay, I would like to spend as much time as possible with my family. Okay, then we have people from Poltava. Can you talk about materials? Zirconia versus feldspathic versus Emax. Milled versus preps. Okay, let's go for this question. So material, it's a huge topic. It's not just for this kind of dental talks before Christmas. We have to maybe do another broadcast about materials. And I'm not a biggest expert in the field about materials, because there are many materials nowadays, many different brands, some modifications, and so on and so on. But we have, let's say, two big groups of ceramic materials. Let's say we have polycrystalline ceramic and we have glass ceramic. Polycrystalline ceramic, it is zirconia or alumina. Alumina we do not use anymore. We use zirconia. And from the zirconia, we have also few generations of zirconia, like a multi-layered yttria reinforced zirconia, and so on and so on. And we have also glass ceramic, which is feldspathic, classic ceramic, feldspathic. Then we have lucite ceramic, which is feldspathic reinforced with a lucite. And we have lithium disilicate or lithium silicate material. So this is what we have. From scientific perspective and also from the clinical experience, we have proved in both ways, scientific proof and also clinical proof, that glass ceramic has a very good bonding to the two structures. So we can use glass ceramic, feldspathic or lucite or lithium disilicate. We can use them for non-retentive restorations like veneers. We can use this for tabletops, veneer lays with non-retentive overlays, and so on and so on. Zirconia, it's very interesting material. It's very hard, very strong, pretty aesthetic, by the way, also. But the only question that we still have in terms of lasting adhesion to the two structures is this micromechanical or chemical adhesion, as glass ceramic has. So personally, I have some internal fears and doubts related utilization of zirconia in minimally invasive, let's say, or non-retentive restorations, because minimally invasive is a little bit not correct the term, because zirconia, for example, if you will do full contour, full anatomic restorations on zirconia, we like E3 reinforced zirconia, katana, for example, from Curare, or from Noritake, or from Ultradent, they have zircad, and it is written in instruction that the minimal thickness for full contour crown, for example, zirconia crown, you can give only 0.405 millimeters, which is very thin, which means it can be superiorly minimally invasive comparing to classic approach for crown preparations. Okay, so for me, zirconia is very interesting. I prefer to wait a little bit like a clinical trials related to bonding to zirconia. So I would start maybe doing these zirconia restorations for posterior teeth, for overlays, because we do a lot of minimally invasive restorations like overlays, veneer lays, tabletops. So I think if zirconia will show us a very good long-lasting results, so we can include this material for that type of restorations. But nowadays, for myself, I prefer to do mainly uh, crowns from zirconia, but for from lithium disilicate or from lucite, from feldspathic, we do veneers and overlays and tabletop restorations. Okay, so that's it. Yeah, let's go we will do some live broadcast, a little bit more detailed in that topic. I will prepare some slides, some case reviews, so that would be more interesting. But that's good point and a good topic for discussion. Okay, so the next thing is what dental intraoral scanner, in your opinion, is the best now and why? I'm studying in Poltava. Abramov, Ilya Abramov. Ilya, nice to see you. Nice to meet you here. I graduated from Poltava, by the way, university. So that's great. So yeah, intraoral scanner. It's a difficult question because I actually don't, I was not able to use all scanners in the market to compare. But when I was choosing the scanner for myself, I read some things about, and also I discussed with my colleagues. I was trying some of these scanners. So I think that Prime Scan from Dentsply Sirona, Prime Scan nowadays from hardware, I mean, the scanner itself is one of the best in the market. The software, but when you do just scanning and then you send your files to your dental technicians, that will be fine. So for me, Prime Scan, okay. But actually, I have no experience with a Trios, with a iTero, and so on and so on. So my opinion, bit subjective in that topic, I think. Which composite brand do you advise to anterior composite veneers? That's the question. Personally, I don't do composite veneers anymore. I did them in the past, like maybe 7, 10 years ago. So all of these new generations of composites are pretty good. From Tokuyama, from GC, from 3M, from Dentsply, all of them they are fine. You need to try composite related to handling. Okay, you need to try by your hands, because some people they really want to work with composites with a small increments. Some people prefer to work with composite with a big layers. So in that case, you have to use composite that keeps shape, because if there are some very soft versions of composite, you place some layers and then you make some anatomy, and afterwards, in few seconds, it melts. Okay, so you need to find one for your hands. For myself, for example, nowadays I can tell you my favorite brands, but again, I'm not trying to force you or to convince you to go for these brands, because I was not able to try all composites in the market to make my conclusions and opinions. So I like to work with Dentsply Spectra. They have very good material for posterior teeth. spectra, and then they have also version for anterior teeth with a dentin and enamel, which is pretty fine. And also I like to work with a 3M Filtech Ultimate, which is also pretty good materials for my hands, and I'm pretty happy to work with these brands. So that's it, actually. Okay, next, let's go for what are the benefits of glycerin gel using after composite restoration? Actually, it's not only for after composite restoration, but also you can use glycerin gel when you do final polymerization, final light curing, when you do bonding of indirect restoration. So the main purpose for the glycerin gel is to cover your resin-based materials. And when you do light curing, the surface of your resin-based material will be cured without oxygen, because we know when we light cure composite, when we light cure bonding, when we light cure cement or whatever, the surface becomes a bit sticky. Okay, so this sticky surface is actually oxygen inhibited layer. Okay, this oxygen inhibited layer can stain very fast when patient smokes or patient eats something, drinks coffee or cola or I don't know, whiskey or whatever. It may stain. So basically, if you will cover your restoration after you do your final layer, you do your initial curing for a few seconds, or like let's say 5 seconds. Okay, and then you cover it with a glycerin, and then you light cure. So this sticky substrate will be polymerized. So that's one of the way to remove this oxygen inhibited layer. But it's not the only one method to remove oxygen inhibited layer. You can also remove oxygen inhibited layer with alcohol, with ethanol. Okay, you can remove oxygen inhibited layer by polishing, but sometimes we cannot remove it from interproximal areas completely, by the way. You can remove it with by air abrasion, but not the aluminum oxide, for example. You can remove it with aluminum oxide, but then you will have to do another restoration, you know. So with the airflow, for example, the powder like glycerin powder that we use for dental hygiene also can help you to remove this oxygen inhibited inhibited layer. Okay. What books or resources about complete rehabilitation you can recommend? How I can learn about bite rising? And what your advice for undergrads? And thank you from Egypt. Ooh, you can, you know, the full mass rehabilitation case and occlusion, it's like religion. We have a lot of dogmas, and we also have a lot of schools teaching occlusion, and each school has its own way, let's say. And sometimes it becomes like a religion sect, you know, and sometimes it also gives a lot of questions rather than answers, especially when people start to go for one school, another one. So then they may be confused. So uh, I would like to say that if you would like to start reading about that just to get some ideas, Mauro Frediani's book, he has two volumes, two books about aesthetic and full mouth rehabilitation. So read it. It's really simple and very affordable style of education in that book. Then Docent for sure. Slavicek, Rudolf Slavicek. It's a very complicated book, by the way, the masticatory organ, but a lot of fundamental things, very deep things related to functional geometry you may pick up from this book. So I would start with a Mauro Frediani, with a docent, and then once you will grow up as professional, probably you will get some references related to this topic, and you will end up, if you would like to go into that field, you will end up with studies. So you will go for continuous education. It's not like just a course. I think it's more like a program because occlusion has to be studied in a long, continuous run sessions of educational programs, not just by the short courses. Okay, Dr. Maxim, what are your favorite books about ceramic restoration? Okay, from dental perspective, because we have also books from dental technicians perspective. Pascal Manier, Bonded Porcelain Restorations. It's a classic. It's like a Bible, but he has now a new book, actually 2 volumes. I have not read them, but I'm really looking forward to get these books and to start reading. Then Galib Gurel, Porcelain Veneers, very good book as well. Stefano Cubi about porcelain veneers, a new book with the videos inside. Very interesting book, very nice, very didactic. I would recommend this book as well. Douglas Terry, he has the huge book about aesthetic dentistry. It's not just about ceramic restorations, but it is about aesthetic dentistry and some interdisciplinary approaches like ortho, some bleaching, and so on and so on. So that's a fundamental book that gives you a lot of answers about aesthetic dentistry, including ceramic restorations as well. Okay. Can you do posterior injected composite tabletops to increase vertical dimension on a patient with a severe tooth wear? Theoretically, you can do that. It may be like a transitional bonding or long-lasting provisional restorations, let's say, because I still prefer ceramic restorations in such cases. But if you will be able to transfer your wax up into the patient's mouth with injectable technique, for posterior teeth as well, it's a good long-lasting temporary solution, I can tell you. In case of severe tooth wear, in a simple tooth wear cases, yeah, I think that it can be also utilized as permanent restorations. Why not? Hello, thank you for the stream. Could you please comment on cementation protocols for non-retentive onlays, inlays, something like Relay X or with ultrasonic activated composite? And so thank you. Okay, so the protocol is pretty simple. It doesn't matter if it is uh, onlays or it is inlays or it is non-retentive or it is retentive. If we speak about bonding, which means you use composite based materials to cement your restorations and you also do some bonding protocol to the tooth structure, the protocol is pretty simple. Ceramic restoration, if we talk about ceramic restorations, you can etch with a hydrofluoric acid, then you can put silane, and then you can use your resin cement. For the tooth, we follow instruction of our adhesive material because we use total etch adhesive systems. We use also self-etch adhesive systems. So you have to really follow this instruction. So when you use total etch, you etch enamel and you etch dentine. If you use self-etch, then you etch enamel and you do not etch dentine. And then you go with your adhesive and then you go with your resin cement. We're a little bit confused with the variety of cement that we have nowadays because we have light curable cements. We can have also highly filled flowable composites that can be utilized as light curable cements. We can have also normal restorative packable composites that can be as well utilized as light curable cements for posterior teeth, for example. So that's the one big group, light curable cements. And we have also dual cure cements, right? So from these dual cure cements, we have classic dual cure cements that you have to prepare two structures with bonding, and we have so-called self-etch and self-adhesive dual cure cements, which you can use without preparing two structures for bonding. You just dry it and then you go. So that's the things that bit confusing us. But if you have possibility to isolate teeth with a rubber dam, I really strongly recommend to follow classic protocol. So you have your ceramic restoration, hydrofluoric acid, sealant, it's done. Then you have your teeth isolated, then you go for etching, rinsing, bonding, then you go with your cement and you bond and you will have results. The only thing is if restoration is thicker than 2 millimeters, in that case I would prefer dual cure cement rather than a light curable cement. If the restoration is thinner, I prefer to use light curable materials like highly flowable composite or specifically designed cement for veneer cementations, for example. Real X you named here, Real X brand, which is from 3M. You can use Real X veneers for for cementation of your indirect restoration if they are thinner than 1.5 millimeters. Can we do, Sina? Can we do onlay or overlay restorations on pulp-cupped teeth? If the patient has pain after restoration, how can we manage the process? Yeah, well, you can. If you diagnose deep caries and you expose pulp, for example, when you prepped caries and you decided to go for direct pulp cupping, then you do your composite build-up, and then you can end up with a indirect restoration like overlay or inlay or onlay. But if, for example, something will go wrong with the pulp, if you get pulpitis, or probably it was pulpitis before, it happens also, or you will get periodontitis, then you can do your excess cavity through your overlay or through your inlay. You do your root canal treatment, and then you restore the excess cavity with composite. So basically, there is no problem with this. I don't feel any problems with that. Uh, can we know your advice for undergraduates? Yeah, keep on learning and don't lose your passion in profession. So that will give you wings, and then you will fly away. Not fly away, you will fly forward for perfection in dentistry. Hello, which scan is better for scanning from multi units, from all in 6-3 shape, Trios 3 or Prime Scan Connect? I have no experience with a 3 shape scanners, so I can just tell you about Prime Scan. Prime Scan is very precise. Prime Scan is very precise, and I'm very happy with this scanner. So I have no, actually, it's not like we have no problems. We have problems with everything, by the way. In dentistry, when you start to do invasive dentistry, even caries treatment, you will have problems, more or less. So, but I can tell from my side that I'm very happy with Prime Scan, and I don't plan to change the scanner for anything else. It's not advertisement. I'm not paid by Sirona, but it's just my personal experience with this scanner. Are you just teaching or also work directly with patients? I also treat patients, not just treating, not just teaching. Okay, not the same way as I treat patients in Ukraine. Unfortunately, due to the war in my country, we had to move to Czech Republic. So treatment of patients in Czech Republic for myself becomes more difficult. Yeah, but anyways. Hello, doctor. Good evening. Could you share some experience in root canal, in root RTC, root canal treatment, trepanation, trepanation? I don't understand the question. You mean access cavity formation, or what do you mean by this question? I would love to just rephrase your question, please, and maybe I will give you some advices. Let's go to our questions from Instagram. In which case, Alexis, the question from Alexis, in which case would you use the injectable molding technique? Low-cost patients and long-term, for example, long-term provisional restoration. So that will be an option, or plastic occlusion, we call it, when we need to test drive occlusion of our patients, or injection molded will be pretty good option. Could you please share the set of drills you use when you prepare the tooth for the crown? That's the question from the Instagram. So just a second. I can check if I have it here. Again, I don't want you to take this as advertisement. It's actually, you can use any kind of boards you want. We use in our practice and then for our courses, we use boards from Comet. I think that you can see here. Uh, Numbers, catalog numbers. Uh, can you or you can't? It's out of focus probably. We can do a screenshot. Ah, okay, and then, but it's not just these ones. I have also some cylindric, some bigger, smaller sizes, shorter bores, longer bores, and so on and so on. Bore matters definitely, but the most important is how do you use the bore? That's more important than the bore itself, to be honest. Protocols, the way you prep, the knowledge that you have in that field, and so on and so on. By the way, if you want to prep like best dentist in the village, I invite you to come to our training center here in Czech Republic in Prague for international groups. We run our courses in English. And in Russian also we do some kind of courses. So you can come and then we can teach you how to prep, how to plan, how to do veneers, and many, many, many other things. Okay, so Instagram finishing protocols after cementation in all kind of preparations. Finishing protocol after cementation. Okay, when you cement your restoration, it depends on the actually depend. Your protocol would depend on the fit of your restoration. If restoration fits well, then you just remove cement. Probably you will use some scalars or curettes, and that's it. If you need to polish something, the Softflex discs it's a good option. The spirals, it's a good option as well. Carbide metal bores, not very good, but if you have a big axis that you cannot cut with your hand instruments, so probably multi-bladed carbide bores may be a good option for access removal of material, but then you have to polish with Softflex and with the spirals, for example. I'm worried about restoration thickness when cementation with heated composite. That's the question from Instagram also. Um my friends, the heated composite is a good option, I think, but it's a bit sensitive in terms of technique. First of all, composite is heated, it becomes soft, but once composite gets colder, it is not that soft as before. So you have to apply some forces to seat it, or you may use some ultrasonic tip to vibrate to seat your restoration. Okay, and then you will have to light cure through this restoration to polymerize your heated composite and so on and so on. I'm not a big fan, to be honest. I'm not a big fan of heated composite as material to cement indirect restoration. I would use highly filled, flowable, restorative composite, like for example, Genial injectable or Spectra Duo Dentin shade. If I want some filled material as luting one, so and I have no problem with the seating because I don't know I don't need to force and so on and so on. So basically, my personal preference is not to use heated composite, regular heated composite for cementation. I use highly filled flowable for that, and I have no problems with seating afterwards. So that's the thing. Okay, so let me check other questions from YouTube, guys. When do you think has What do you think has shaped you into the doctor you are today? What do you think what the key to your success? And it's a long topic. Actually, maybe next time we will speak about some motivation in dentistry and so on and so on. Because I'm planning to finish our live broadcast in 5 minutes. So thanks for the question, by the way. But next time we will do some motivational dental talks, and probably we will discuss this kind of stuff as well. By the way, thanks. I would like to thank everybody for your questions, for your interaction in this live broadcast. I really appreciate your time and efforts and impact in dentistry. So let's do two last questions, and then we will do our next live maybe next year. But it will be very soon. In almost 9 days, we will have a new year. So hello, can you share your favorite materials and brand for adhesive dentistry, composite for anterior and posterior teeth, bonding system, adhesive system, etc. Okay, let's go. My favorite bonding agent, Optibond FL Care Company. My favorite sealant for ceramic is Bis-Silane from Bisco to bottle system. My favorite material to cement restorations, if they are thin and I can use a light curable, so they're my favorite too. Genial Universal Injectable and Spectra Flowable Duo from Dentsply. So actually, it's not a cement; it is a highly filled flowable composite, and I use this type of composites for veneer cementation, for example, for overlay cementation if they are thinner than 2 millimeters. If restoration is thicker, for example, and the crown or overlay, I use cement from Dentsply, which is called Calibra Ceram. This is what I use for thick restoration for cementation. So basically, this is my answer. Which adhesive system and material used for post cementation? For post cementation, I use yeah. The question was, can you talk about your protocol and which adhesive system and material you use for post cementation? For post cementation, I use core material. For example, I insert post and I do my core build up. Just an example. In this case, I can use dual cure core build up material like Rebuilda, for example, from Voco, or Luxacore from FK from DMG, right? DMG, yeah. Then we can here have Core X Flow from Dentsply, for example, and they have their own courses, the fiber post system. So I just take this fiber post. It has to be disinfected, cover it with a adhesive, dry it, light cure it, and then you prepare your root canal. Then we use our adhesive system that is recommended for this dual cure core build up material. Then you fill your root canal with a core build up material. You put your post, and then immediately you continue creating your core actually. So I used that technique for post and core together. Hello, so from Saudi Arabia, how do you decide if direct composite restoration for posterior tooth isn't suitable and an onlay is better option? Okay, that's the question, and I will give you answer for that question right now. Just give me a second. I will send you link directly to this chat. Let's go. And there is a webinar on our YouTube channel, free of charge, very informative, for almost 30 minutes or even more. Let me just double check. We go for playlists. By the way, when you are in this, since you are in this channel, what you can do, you can first of all sign up, okay, to follow us. We will be more than happy. Then put likes to this video for sure, and then you go to our main page in this YouTube channel, Belograd Academy. Then you can go to playlists, And out of this playlist, you may find webinars. And when you go to the webinar, there is a webinar that is called On Lace Basic Principles webinar. So just give me a second. I will copy this link and I will paste it to this chat, and you will be able just to go immediately and not read, and watch the material about posterior indirect restorations. And we were discussing there in which case I can go for direct, in which case I have to go for indirect, in which case we do cost reduction, in which case we do inlays, and so on and so on. Okay, my friends, it's almost an hour, actually 15 minutes live. It was very good time spending together. Thank you for your questions. Thank you for your time. Thanks for being with us. Thanks for following us. Thanks for your help. I will be more than happy to see you in our training center, in our BG Dental Academy in Prague for our hands-on courses. I would like to wish you for the new year to be strong, to be motivated, not to lose interest in your profession. I know our profession is very interesting. Our profession is very motivational. Our profession is very humble. Our profession is very noble. And due to our profession, we can develop ourselves as professionals and also as human beings. And I would like to wish you to still fall in love with our dentistry, with our profession. I would like to wish you to be more perfect in what you do, to get easy protocols for everything you do, to enjoy everything that you do, and to have patients that are easygoing, that are very easy to work with, and patients who can afford everything that you do in modern way. Stay strong, my friends, and may the dental force be with you. Bye bye. See you soon.